Anderson, over to you, please.
Okay, thank you, Amarachi. Good morning, dear esteemed participants.
Anderson, there's a problem
Ladies
with your talk. We cannot hear you. Anderson, we cannot hear you. Anderson, we cannot hear you.
Colleagues, can you hear me?
It's breaking up. There's a problem with the internet that you're connected to. Can you hear me?
Colleagues, can you hear me?
We can hear you now. It's breaking up.
Amarachi, I can hear you.
Correct.
Can you hear me now?
I can hear you now clearly.
Okay, so apologies for the internet connectivity. So if you can hear me now, can I start?
Yes, please go ahead.
Amarachi, can you hear me?
Yes, please go ahead. Can you hear me?
Yes, I can hear you loud and clear. Okay, good morning, colleagues. Good morning, ladies and gentlemen, on meningitis sequelae. My name is Dr. Anderson Latz. I am the meningitis focal person for the EPR cluster in Afro. I'm sitting at the Dakar Emergency Hub. So we'll be having 2 hours of discussion on meningitis sequelae. Meningitis sequelae is one of the innovation of the global roadmap to defeat meningitis, which is also translated in the African region through a framework which was adopted in 2021 by the regional committee, member states of the African region. So for today's session, we'll start with the opening remarks from Dr. Impuma will be. So without taking too long, let me give the floor to Andre to give the opening remarks for this webinar.
Anderson, apologies. Would you like to do the housekeeping before the opening remark? Anderson, can you hear me? Anderson, can you hear me?
Distinguished participant, ladies and gentlemen, on behalf of the Director of Communicable and Non-Communicable Disease of WHO African Region, I have honor and privilege to open this webinar on meningitis sequelae in WHO African Region. Meningitis is a devastating disease and long-term complication. An estimated 1.6 million cases and over 236,000 deaths were reported in 2019 worldwide. and across of all age, with 1 on 5 affected individuals living after the acute phases with long-term disability sequelae. Despite significant progress made in combating meningitis over the past 10-20 years, including introduction of new vaccine as Menafrivac, meningitis epidemics remains major public health challenge in African meningitis belt. The cost of meningitis epidemics to patients, their families, and the community is high. Acute meningitis can have severe complications and leave people with long-term neurological sequelae, such as hearing and vision loss, seizures, neuropsychological impairment, etc. Many people will also experience a range of less serious after effects that are not always immediately apparent. For example, emotional difficulties. In people who have experienced meningitis, such as adolescents and young adults, self-esteem, friendships, well-being, and school performance can be impacted. Lethality and morbidity due to meningitis remains high in low and middle income countries, including in sub-Saharan Africa. There are many gaps in guidance and implementation of treatments and care of meningitis, such as delays in diagnosis and treatment, lack of consensus when it comes to antibiotics, and non-recognition and care of sequelae. During the regional committee held in August 2021, all the member states of the African region endorsed the regional framework to implement the roadmap to defeat meningitis. These regional frameworks envisions to make Africa free of meningitis by 2030. This regional framework was officially launched by the WHO African Regional Director in September 2022. The regional strategy planned to raise awareness of health workers and policymakers on meningitis sequelae. That also includes NGOs, civil society communities. So to really raise awareness when it comes to burden, early detections, and confirmation, care, and rehabilitation. This webinar is in line with these objectives. Dear participants, ladies and gentlemen, the general objective of this webinar is to strengthen capacities on meningitis sequelae in the WHO African region, and is expected that after this webinar, countries will have a group of health personnel who will be knowledgeable in their specific orientation and areas of work to understand management of sequelae and future direction in African region. I wish to all fruitful webinar. I declare this webinar on meningitis sequelae open. Thank you for your kind attention.
Thank you very much, Dr. Andre Bita, who made the opening remarks on behalf of Dr. Benido Impuma, the director of UCN at Afro. So, colleagues, let me now share a few slides on the housekeeping rules of this webinar. I hope everyone else can see my slide.
Yes, we can. Please go ahead.
Okay, thank you. Before we start, please note that this virtual training adheres to the Code of Conduct to prevent and respond to sexual misconduct, including sexual harassment, abuse, and exploitation. All participants have access to show captions, Q&A, chat, reactions, raise hands, and interpretation. All participants should have their microphone and camera disabled. If you wish to take the floor, please raise your hand and your microphone will be activated when the presenters will invite you to talk. On questions and chats, use question and answers feature for questions regarding the topic and presentations. Only questions in the Q&A will be answered during the sessions. Responses may occur live during the event or replied privately or publicly for the benefit of other attendees to see. Please use chat feature for questions regarding IT or logistics. Chat may only be used by presenters to share important links, contact information, and so forth. There is interpretation in English, French, and Portuguese by clicking the interpretation button. Click on interpretation and choose the language that you would like to hear. To hear the interpreted language only, click mute original audio. Please note that the interpretation of proceedings serves to facilitate communication and does not constitute an authentic or verbatim record of the proceedings. Only the original speech is authentic. Click on show captions and caption will appear on screen. To close the caption, click hide captions. On recordings, materials, and feedback, please note that by participating in this webinar, whether as participant or panelists, we take your attendance as permission to record your contributions and share the recording via various channels for continuous learning purposes, including YouTube, LinkedIn, and other platforms. Session materials, including session recording, will be shared with the participant in the days following the webinar. Subscribe to the WHO EPR YouTube channel to have access to all webinar recordings. As we continue to improve our training programs, your feedback is invaluable to us. A survey will be shared at the end of the session. We highly encourage you to share your thoughts and suggestions. Your input will help us tailor future sessions to better meet your needs and expectations. Ladies and gentlemen, this is the agenda for today's webinar. After the welcome remark, I will share a couple of slides on the objectives and outcome of this webinar. Then we'll have a presentation on the framework to defeat meningitis by 2030 in the African region, vision, goals, and future directions from my colleague, Andre Bita, with the regional meningitis focal person, UCN Afro. After that, we'll have a presentation on the management of meningitis sequelae, which will be made by Nicoline Schiss from HQ, from the Brain Health Unit. Following the presentation on meningitis sequelae, we'll have another one on the burden and surveillance of meningitis sequelae by Lorenzo Pezzoli from the HQ meningitis team, emergency meningitis team. The next presentation after the one from Lorenzo, we have Susan Merin from National Institute for Communicable Disease in South Africa will take us through some slides on the importance of meningitis sequelae surveillance with the experience from South Africa. And then we'll close with a Q&A session, which will last approximately half an hour, and then we'll have the wrap-up. So I'm wishing you all a good webinar. So what are the objectives and expected outcomes? Contribute to the reduction of disability and the improvement of quality of life after meningitis due to any cause. Specifically, we wish to provide an overview on the regional framework to defeat meningitis by 2030 in the WHO African region, and to increase understanding on the burden of and surveillance of meningitis sequelae among stakeholders. And lastly, is to share guidance and experience on the management of meningitis sequelae with stakeholders. So at the end of this webinar, we expect that an overview on the regional framework to defeat meningitis by 2030 in Africa is provided, and we have an increased understanding on the burden of meningitis sequelae among stakeholders, and also knowledge on meningitis, on the management of meningitis sequelae is improved. Thank you so much for your attention. So as per today's agenda, now we have the presentation on the framework to defeat meningitis by 2030 in WHO African region. Specifically, we'll focus on the vision, the goals, and future direction. I just want to remind all participants, if you have any question, just go to the Q&A and type in your question, and the panelists will endeavor to provide answers to your question. So Andre, over to you for your presentation on the regional framework to defeat meningitis.
Thank you for this opportunity and privilege to present the framework to defeat meningitis by 2030 in African region, vision, goals, and future direction. I will emphasize the topics of meningitis sequelae. As content, I will present the background, the vision, scope, strategic goals, strategic direction of the regional framework, outcome as well. Progress status of meningitis sequelae in African region, challenge and perspective. Meningitis is a serious infection of the meninge, the membrane covering the brain and spinal cords. Meningitis is a devastating disease with a high case fatality rate. Around 1 in 6 people who get this type of meningitis died, and 1 in 5 have severe complications as seizure, hearing and vision loss, etc. Despite tremendous efforts made in the past 2 decades to combat meningitis, it remains a burden globally, especially in African meningitis belts. Effort to reduce the burden of meningitis led in 2030 to the endorsement of the global roadmap to defeat meningitis by 2030 during the 73rd World Health Assembly of WHO. Following that, WHO African region developed its regional framework to implement this roadmap, which was endorsed by all the 47 member states in 2021 during the regional committee. And this regional framework was officially launched by the regional director of AFRO in September 2022. The vision of the regional framework is towards an African region free of meningitis by 2030. So the specific strategic goals related to meningitis sequelae among the 4 that were endorsed are to reduce disability and improve quality of life after meningitis. And the strategic target is more than 50% of people affected by meningitis receive adequate support and care. The second one is to build resilient, well-resourced, and integrated national meningitis program in countries of the African region. And the strategic target is more than 80% of national meningitis program in countries of the African region are resilient, well-resourced, and integrated. That means that meningitis sequelae is also included in this program. As strategic direction, we have upgraded the quality of meningitis case management and care to reduce deaths and disabilities and improve the quality of life after meningitis, enhance meningitis surveillance, and leverage data analytics and evidence to drive progress. How about the outcome? We have several outcomes, but the outcome related to meningitis sequelae are improved tools and access to diagnosis and treatment of meningitis, improve monitoring of meningitis epidemiology through disease surveillance, improve access to support and care for people and families affected by meningitis. As progress status of meningitis in the African region, a primary two-pager on meningitis sequelae on identification and management was developed by WHO health workers. This primary two-pager was shared to countries to help them to develop the national plan to defeat meningitis by 2013. Currently, we are working WHO partners and experts from countries in African meningitis belt and other regions to develop the global guidelines that will really define cases, present diagnosis, treatment, rehabilitation, and surveillance on meningitis sequelae. Follow-up of meningitis sequelae have been initiated during the response to meningitis outbreak experienced by the Democratic Republic of Congo and Nigeria. What are the challenges? Coordination between programs to improve working with disabilities. We have surveillance, laboratory, clinician health promotions, etc. Community mechanism and structure on meningitis sequelae, identification and management to be improved. Community engagement, civil society and NGOs to be also involved in these battles. Capacity among health workers on the identification and management of meningitis sequelae to be enhanced. Infrastructure and equipment for adequate management of meningitis sequelae to be improved. Resource mobilization for meningitis sequelae to be reinforced. Partners to support disability should be increased. What are the perspectives related to these challenges? Finalize the guidelines and strengthen capacity of health workers, NGOs, civil society on meningitis sequelae. Continue to support countries to incorporate meningitis sequelae surveillance and management in their national plan to defeat meningitis. Promote meningitis aftercare with identification of key stakeholders in countries and regions. Mobilize resources for the development and implementation of national plan to defeat meningitis by 2030. And conduct surveys to assess the burden of sequelae caused by meningitis and other conditions in our countries and the regions. Thank you for your kind attention.
Thank you so much, Andre, for this wonderful presentation, which provides an overview on the regional framework to defeat meningitis by 2030 in the WHO African region, focusing on issues of meningitis sequelae. So, ladies and gentlemen, now let me give the floor to our colleague Nicoline Schiss from WHO HQ to make a presentation on the management of meningitis sequelae. I would like to remind all participants that if you have any question, please put it in the Q&A. Panelists will provide answers to your questions as they come up. Besides the Q&A function, we'll have half an hour session on question and answers, which will be provided live. Nicoline, over to you.
Thank you, Anderson. So good morning and good afternoon. It's a great pleasure to be with you today to talk about the management of meningitis sequelae. My name is Nicoline. I'm a neurologist and a technical officer at WHO headquarters in Geneva, Switzerland. I want to say that I'm so glad that this webinar has been organized, and I'm very happy that the topic of meningitis sequelae is coming to the forefront of the discussion on meningitis. Many people and their families are in great need of help in order to manage meningitis sequelae. Next slide, please. So as many of you already know, meningitis imposes a high burden in Africa and also across the globe. In the latest GBD data published on neurological disorders up to 2021, meningitis ranked number 6 in the world for global disability. It was even higher when we were looking at different regions within the African region. A disproportionately high rate of disability occurs in Africa, mainly due to elevated endemic disease, a younger population, and regularly occurring epidemics across the meningitis belt. Next slide, please. And so what do we mean when we talk about sequelae? So Andre has already described the different types of sequelae that can happen after meningitis. They include seizures, hearing and vision loss, limb loss, weakness, problems with cognition and memory, and very importantly, developmental delays in children. And while hearing loss and seizures are the most commonly identified sequelae, there are often more subtle deficits such as cognitive impairment and developmental delay that also affect a large proportion of people. Malnutrition, immunocompromised conditions, and delays in diagnosis and treatment are particularly hard felt and can affect the development of sequelae. The risk of suffering from some type of sequelae after bacterial meningitis is almost 3 times higher in Africa and Asia when compared to Europe. And this is mainly due to treatment delays, the length of the travel to receive care, lower immune defenses that can happen from malnutrition, and the tremendous cost of hospital care on families. Next slide, please. We also know that social and economic factors can dramatically affect people's ability to perform in school or to obtain gainful employment. Cognitive and behavioral difficulties may only be noticed once a child has started school. Many times they remain completely undiagnosed, and these children struggle to keep up in school. They are labeled as delayed, and they drop out or flunk out of school, which sets them up for a lifetime of limited opportunities. Caregivers, often mothers, are forced to choose between care for their disabled child instead of working to generate an income or to provide for other siblings. Brothers and sisters sometimes do not have the money anymore to continue in school. And so the consequences of having a disabled child in the family affects all the children in the family. Even if people have access to public health services, the costs associated with medical care can be financially devastating to families, as personal household earnings or savings may not cover many of the expenses of hospital care. Next slide, please. And as limited as the data are for sequelae in children, it is even worse when you try to find data related to adolescents and also how adults fare in the aftermath of meningitis. The implications for someone disabled as a child are very, very different from someone who is disabled as an adult. For young adults and adolescents, self-esteem, friendships, school performance are all important aspects of a good quality of life. And problems in these areas can also affect parents, caregivers, and the community. Most important is the recognition of these sequelae as a first step in order to provide equal opportunities for care, rehabilitation, specialized education, and employment. Next slide, please. Many, many people who have disabilities do not know that resources are available to them. They are often overlooked by individuals and also are not told about these from medical practitioners who are focused mainly on providing care for people with meningitis. Resources include disabled people's organizations run by and for people with disabilities, and disability-focused government services and charities that are available to all disabled members of the community. Some organizations can be found at both the local and national levels in both high-income and low and middle-income countries. They can help with education, employment, and advice on social services and economic support programs that are available through government agencies and local charities. Importantly, these organizations can advise people who are disabled by meningitis on their rights and their entitlements as is designated under local and national disability law. These are important issues to be aware of, and this type of information, or the lack of information, are a part of what we are currently trying to research and address at WHO. Next slide, please. And so this brings me to the work that we are doing on meningitis sequelae. As many of you might be aware, the Defeating Meningitis by 2030 Roadmap is a WHO initiative that is spearheaded by 3 separate WHO departments: the Department of Mental Health, Brain Health, and Substance Use, the Department of Immunization, Vaccines, and Biologicals, and the Health Emergencies Program. We all work together to try and advance the agenda of the Defeating Meningitis Roadmap. The roadmap has 2 pillars that are very important in the upcoming meningitis guidelines. Pillar number 2 talks about diagnosis and treatment, and pillar number 4 talks about support and care for people affected by meningitis. Next slide, please. So we are currently working on meningitis guidelines for diagnosis, treatment, and care that we hope will be directly applicable to any and all settings across the globe. It is a long process. We've been working on it for several years. And this is a diagram to show you the process of guideline development at WHO. It's a very rigorous methodology, and it looks very, very closely at the evidence that is available. We first conducted a scoping review to determine what has already been published on meningitis and meningitis sequelae, and what are the major gaps and how can we improve these gaps. We then set up an international group of experts in various areas of meningitis diagnosis, treatment, and care to form what we call a guideline development group. This includes people who have had meningitis or family members of people who have had meningitis, doctors working in different specialties of medicine, such as neurology, infectious disease, and rehabilitation, as well as experts in epidemiology, health systems research, disability, and medical ethics. This past May, we had our last meeting with the GDG to review all of the evidence available and to finalize some draft recommendations. The yellow arrow on this slide shows you where we are in the process right now. We are finalizing the draft recommendations, and we are very much hope that they will be ready and published by the end of this year. Next slide, please. The target audience for these new WHO guidelines on meningitis diagnosis, treatment, and care includes healthcare providers who are working at first or second level facilities, including basic inpatient and outpatient services, particularly with a focus in low and middle income settings. Policymakers, healthcare planners, and program managers at the national and international level, and also academics and researchers. Next slide, please. So this is a very busy slide, but in my opinion, it represents one of the strongest points of the WHO roadmap and the meningitis guidelines. You will see that there are many interlinkages between the upcoming meningitis guidelines and other WHO departments and initiatives, particularly with our pediatric colleagues and colleagues working in HIV, TB, rehabilitation, medicine access, and diagnostics. It's this connection and interlinkages that we are hoping will really make our guidelines very, very strong. In particular, you will see in the lower left-hand corner, the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, which we are implementing as a complement to the roadmap in the Brain Health Unit. I will talk about this in a few slides. Next slide, please. So these guidelines will cover all ages, except for the newborn period, which is already covered in other separate WHO guidelines. They will also address both epidemic settings and non-epidemic settings. We have focused primarily on acute meningitis, since subacute and chronic meningitis conditions, such as TB meningitis and cryptococcal meningitis, was far beyond the scope of the guidelines. However, some of the sequelae questions that we have addressed are also relevant for people who have subacute and chronic meningitis. Next slide, please. Within the guidelines, there are 4 main categories that we focused on. The first category is the diagnosis of meningitis. The questions we looked for evidence on optimal cerebrospinal fluid testing, including PCR testing and peripheral blood testing. The second and the third categories are treatment questions, including adjunctive treatment, such as corticosteroids and osmotic agents, as well as antibiotics and antimicrobial medications. Finally, particularly important for our webinar today, the fourth category addresses the detection and treatment of meningitis sequelae. Specifically, we focused on whether people who have meningitis should be screened for sequelae, particularly before discharge from the hospital, and how do we facilitate rehabilitation for people who have sequelae after discharge from the hospital. So as you know, after being in the hospital with meningitis, many times people leave and they have no follow-up. They have nobody to tell them how they can manage sequelae. They have nobody to detect whether or not they have sequelae. And this is a large population of people that we are really trying to capture so that we are able to provide as much help as possible after the discharge from the hospital. Next slide, please. All right. So this will also tie in to the a closely related WHO action plan that is interwoven with the work that we are doing on meningitis and the Defeating Meningitis roadmap. So for those of you who don't know, in 2020, the WHO headquarters established a special unit that is focused on brain diseases and neurological disorders. No, one slide back, please, Andrachi. Thank you. This action plan was unanimously endorsed by member states, and it was a very important recognition of neurological disorders, including meningitis and other brain infections. And it established a strong foundation for the integration of neurological disorders into the broader public health agenda. The name of the action plan for neurology from the Brain Health Unit is called the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. It's a very long name, might not be very easy to remember. So generally, we shorten this long name to the IGAP. Next slide, please. So this is a brief overview of the IGAP. It outlines 5 strategic objectives with recommended actions and associated global targets, almost all of which are directly applicable to meningitis. The areas focus on political prioritization of brain disorders, the diagnosis, treatment, and care of people who have any disease that might be affecting the brain or the nervous system, promotion and prevention, research, innovation, and information systems, as well as specific opportunities for system strengthening through building country capacity for epilepsy in particular. The idea here was that we use one neurological condition. Amarachi, back, please. Back to that first slide, the one previous. There we go. The idea here, if you will see, is that we are using one neurological condition, which is epilepsy, to try and build system capacity for all neurological conditions. And as you know, epilepsy is a often devastating sequelae of meningitis. And so we have a very particular strategic area here for epilepsy following meningitis. Next slide, please. Here are some more tools that we have produced in the Brain Health Unit to help countries, clinicians, and people with sequelae to improve their care. In particular, the upcoming meningitis guidelines, which I've told you about, and also we are having some associated job aids for the diagnosis, treatment, and care of sequelae, and also an upcoming technical brief that we are currently working on encephalitis. And as you know, the sequelae for encephalitis and meningitis are very similar, and their treatment can happen in the same manner and in the same ways. Next slide, please. So finally, a very big thank you to everybody who organized and everybody who attended the webinar today. There is so much work that we need to do in order to help people with meningitis and their families and their communities. And I look forward to doing this together with everyone. Thank you very much. Back to you, Anderson.
Thank you so much, Nicolene, for this brilliant presentation. I think we have a lot to do when it comes to detection and management of meningitis sequelae. Thanks once again. I would like to remind participants that we have the Q&A to ask your questions, and some of the questions are coming up. So I'm inviting panelists, to check the Q&A and provide answers to those questions from the participant. Thanks so much to participants who have, asked those very relevant questions. So now let's give the floor to Lorenzo Pezzoli from WHO HQ, from the meningitis team of the emergency component of meningitis, to make his presentation on the burden and surveillance of meningitis sequelae. Lorenzo, over to you.
Thank you very much, Dr. Anderson, and good morning, early afternoon to everyone. It's a pleasure to be here and to speak about sequelae and to follow a brilliant presentation just presented by Nicolene. This is very much in line with what she presented, and it is talking about the burden, not so much, and especially the surveillance of meningitis sequelae, because as we just heard, the important bit of our roadmap when it comes to sequelae is about detection of these patients, and it's about capturing in the health system so that we can do actions to provide the appropriate care and guide our national meningitis elimination plans. I'm the team lead for the epidemic control of meningitis, which is housed in WHE. But as we all know, the roadmap within WHO is hosted by three main departments. One is the UCN Brain Health Department unit, represented by Nicolene. We have the emergency program, and then we also have, of course, the IVB and the vaccine preventable side of the house. We are one big team across all the three levels, and so labeling is relative here. The important thing is that we know that all our work is complementary. So I think we already covered this, but what are meningitis sequelae? These are the long-term complications following meningitis infection. The most common are hearing loss and cognitive deficits, physical disabilities, of course, the loss of limbs, for example, or loss of motor functions because of neurological disorders, cognitive and behavioral effects, and also not to be underestimated the psychosocial impact of this sequelae on the life course of a patient: depression, anxiety, social isolation. And over the life course of a person affected by meningitis, this can build up because sequelae, unfortunately, are chronic conditions that are unlikely to go away, and they accompany a patient for the rest of their lives. And they incur healthcare costs, and of course, they accumulate. And we have estimated that on average, if we compare it to the acute care and the cost of acute care, this can be 10-15 times more costly and more impactful on the life of a patient and their families. So it's a problem that is definitely urgent to tackle. And in our roadmap, I think we have already seen some of these figures, but we have 2.5 million cases of meningitis occurred in 2019. This is the data from the roadmap. It's updated from the time when the roadmap was published a few years ago, but I think the situation hasn't really changed that much. 1 in 5 people suffering from meningitis can have these long-lasting disabilities, and 1 in 6 actually die. 15 to 20 million people then are estimated to live with sequelae, at least in 2019, and meaning that we had 16.3 million disability-adjusted life years in 2019 only because of bacterial meningitis. Nicolene and Tarun's team have also participated in a recent publication led by the Global Burden of Disease group, where they have estimated the global burden of disease of all neurological conditions, and they have seen that meningitis ranked among the top 10 neurological conditions globally, especially with a higher impact on children under 5, where it was actually the second leading cause of disability. Of course, this has a lot of regional and demographic variation. The highest burden of meningitis and then, of course, of sequelae, it's logical, is in the sub-Saharan Africa. Males are slightly more affected with a female-to-male ratio of 0.87. And young children bear the highest burden. To end on a positive note, the paper also highlighted that there's been a lot of progress in tackling these chronic conditions. DALYs decreased by 56% from 1990 to 2021, with mortality also dropping by almost 50%, and prevalence also dropping 35.5%. And this is obviously due most likely to the impact of vaccination. We have talked about the introduction of the Menafrivac, the meningitis A vaccine that has effectively wiped out the major cause of meningitis epidemic. We are now introducing the Men5, which is an improved vaccine compared to the Menafrivac, which covers additional 4 serogroups. And this obviously is driving a decrease in prevalence of acute cases and, of course, also of this chronic sequelae. Of course, challenges remain because the issue at hand is very complex, as was highlighted also by Nicolene. It is often seen naturally, in a way, so as a secondary priority, because the first priority when you have a meningitis epidemic, of course, becomes the immediate health concerns, the acute cases. Detecting sequelae kind of goes a bit as a secondary priority. And unfortunately, in many settings, there is still poor follow-up for these patients once they have suffered an acute episode, to capture them in the health system. And this results in an overlooked long-term impact. We know that the devastating long-term effects of meningitis are underestimated because we don't have ways to capture them and to monitoring them. We do have ways, but we have systems that are not as good as we would want them to be. We will hear, for example, from Susan about a good example of a system that is working towards that, and many countries do have systems. But on a general level, this is still not where we would like them to be. There's also a fragmented response because often the efforts have been pathogen specific, neglecting the fact that we do have a syndrome and an impact of all-cause meningitis. This is actually a snapshot of before the roadmap, because now the roadmap is changing this focus. As we know, the roadmap focuses on all-cause meningitis, predominantly bacterial meningitis, but then especially with regards to sequelae, with regards to focuses on all-cause meningitis, and it's helping to change this urgently to change the focus with a growing recognition that there is a high economic and societal burden of the sequelae that needs to be addressed if we want people to live healthy lives for as long as possible. And this is really the vision of the roadmap, a unified global strategy that offers the first cohesive approach, not only to the prevention of the acute cases, but also to the management of the sequelae. I presume we already seen this, how the sequelae work is cited housed in the roadmap. We're talking especially about Pillar 4, which is the pillar Nicolene just talked about, the support and care for people affected by meningitis, but it does have an overlap with all the pillars, diagnosis and treatment, and in this case, we're talking about surveillance. So how we can conduct surveillance of sequelae, just like we do of acute cases. You have heard also the great news, the great advancements, and this is a picture to the right of the group of experts. A selected group of experts. A lot of them were also online, but they were in Geneva, that met 2 times the GDG, the Global the Guidance Development Group, to define the clinical guidelines that Nicolene just talked about. All this is part of our visionary goal 3, which is reduce disability and improve quality of life after meningitis to any cause. So what is needed in terms of surveillance? We need to reinforce the capacity to detect the sequelae and capture them in the health system. So generate the information for our roadmap to be really put in action. And for this purpose, in July 2024, there was a meeting in Geneva. Many of us here, panelists, were also participating in that meeting with a lot of country experts to discuss how to better understand the impact of sequelae and the unmet need for support services to improve care and support for people with sequelae. And we discussed that there were two ways to approach this question. And the two ways are complementary. One doesn't exclude the other, and they should be pursued in parallel, absolutely. One is a research protocol. Research is always needed to assess the burden, to conduct specific experiences and operational research. And we have launched a protocol that will address this. But then, since research is by nature focusing on very specific areas, very specific situations, we also said that we need a generic surveillance protocol that Ministry of Health and national authorities can apply in order to guide their public health actions. And as it is of this second part that I will especially talk today. The main objective of this surveillance protocol is to measure the prevalence and types of sequelae at the time of discharge among patients with laboratory confirmed meningitis in a given area to provide data to inform public health policies. This is really essential. We need to know who is affected by sequelae to inform our strategies. And we need to do this at least to the laboratory confirmed meningitis cases. As a desirable, as we have suspected cases and we include them in our surveillance for acute cases, we should also consider if patients with non-laboratory confirmed meningitis can be captured by such a surveillance system. And the data collected will help strengthen post-discharge care plans, develop sequelae, and we also need to, of course, for this to work, just as we do for acute cases, develop specific sequelae case definitions that are based on the local context, so that they can be detected and monitored. A secondary objective of this project initiative is to determine the burden of sequelae among the vulnerable groups and to guide the allocation of resources. To identify also the risk factors associated with the development of sequelae, knowing, for example, if you see a patient in an acute phase, you already have some red flags because there are some risk factors associated to that infection. You know that you will have to enhance their follow-up in order for them to ideally prevent the sequelae from occurring, or at least mitigate their effects. As a desirable secondary objective, we would like also to use this data to assess the financial burden on survivors and their families. As we said, 10, 15 times the burden of an acute case is something that shouldn't be overlooked, and we should help as a global health community, countries, to support their loved ones and to care for them. And of course, also evaluate the quality of life for affected individuals, which helps informing the policies. We talked about DALYs, the disability adjusted life years. With this data, we can address those important metrics, seeing how much quality adjusted life years, or DALYs, meningitis sequelae incur, and ideally demonstrate that our roadmap is progressing towards their elimination. The target population for these surveillance systems, well, as we said, essentially should be the patients with laboratory confirmed meningitis who have been discharged and are, of course, alive. Desirable, the population includes both laboratory confirmed and clinical suspected cases, as we said before, to ensure a comprehensive surveillance. The implementation, just like we do surveillance for the acute cases, we will use the trained health professionals, the clinicians, once they see these patients, to ensure that they are captured and potentially also conduct patient interviews. This is, in essence, a case-based surveillance, which is something that many countries already do for the acute phases. And this comes to data collection. We need to as an essential requirement, collect data at the time of discharge using existing meningitis surveillance systems, for example, the electronic case-based surveillance, to avoid duplication of efforts. We will not create a parallel system. If a country has already the capacity to conduct case-based surveillance for acute cases, then it is natural that they will use the same system to capture also the meningitis sequelae to avoid duplication. If resources permit it, we will also extend data collection with follow-up visits 2 months after discharge, because we know that for acute cases, they are captured only once when they go when they have their first contact to the health system. For sequelae, if they happen after they have been discharged, we need to have systems that allows us also to extend this follow-up and detect sequelae that happen a few weeks or a few days after discharge. This is the surveillance flow chart that we have discussed at that meeting. Of course, this is something that will be validated by our working groups, by our countries, so it's work in progress. But we start with the question if this is a sentinel hospital that already conducts meningitis sentinel surveillance. If it is yes, then we know that those countries, those hospitals already do case-based surveillance. And it is just a matter, I mean, I say it's easier said than done, but it is just a matter of scheduling up a follow-up and enroll the patient within the case-based surveillance, use the questionnaire, and make sure that there is this rehabilitation service questionnaire 2 months after. If it's not a surveillance system, it's a surveillance hospital, the second question is, does this hospital, does this health facility use the case-based surveillance? If yes, well, pretty much the process is very similar. If it's not, then at least if they don't do case-based surveillance, but they do aggregate surveillance or other type of surveillance, then at least we would want them to collect demographic and clinical and laboratory data, just like we do for aggregate surveillance. This is just an example of the form. It is intended as a very simple form that would be like an annex or something that it is attached to the case-based surveillance form. And in many cases, it is already in place. We'll not go through the whole variables unless there are specific questions that we may go to later. And an essential part of a surveillance system is then analyzing and measuring the results. For that, for our analysis, it will be essential to stratify the data by pathogen, by serogroup, by serotype. We have heard that not all the pathogens may have the same risk of developing sequelae, not all the serogroups. In terms of patients, we need to describe their age, their gender, their vaccination status, and all the other demographic variables to have essential good information for action, and analyze the trends in sequelae outcomes to identify high-risk groups and areas in need of intervention. The desirable with our analysis is to go a bit more deep in the analytics part, identify the risk factors, complete logistic regressions and all other type of analytical methods, and also assess the impact of interventions. For example, do an impact of analysis every time there's a vaccination campaign, demonstrate that not only the acute cases go down, but also that the sequelae are reduced. Any surveillance system will also have to consider feedback loops and data sharing with the hospitals, with healthcare providers, with the public health institutes and stakeholders if we want the health system to drive effective actions to manage the sequelae. And we will integrate this data into existing surveillance dashboards. We have heard, we know that most of the countries in the meningitis field participate in the enhanced surveillance and in the meningitis bulletin that is facilitated by our colleague Clément. And ideally, once we have surveillance systems that provide the data on sequelae, this data will feed in the same exact dashboards. And desirable, we put it as desirable, but ideally this is in reality essential. Produce narrative reports on a quarterly or 6 monthly basis to show the results of the surveillance systems. And last but not least, with this data, it is the advocacy and strategic part. We need a high-level engagement and advocacy to use this data for as a public health good at the country level, to guide the allocation of resources, to support strategic actions to manage meningitis sequelae, to inform training programs, and ideally not only use it in our own healthcare professionals, surveillance experts forums, but also use it to collaborate with patient advocacy groups, policymakers, civil societies, and ensure that, as I said, this data is really a global good that can support the implementation of the roadmap at country level, at regional level, and at the global level. That's all I wanted to talk about. It is a project that is at the inception phase. It is a very ambitious project, very exciting. And any feedback from the countries, any questions, any comments would be really appreciated, because we are in the process of gathering ideas on how to implement effective meningitis surveillance, and we need the support of all of us here for that. Merci for your attention. Merci pour l'attention. Thank you for your attention. Obrigado pela atenção. Back to you, Anderson. Thank you.
Thank you so much. Thank you so much, Lorenzo, for this wonderful presentation. Thanks a lot. We have learned a lot, and some of the participants are requesting to have the presentations of this webinar. I will make sure that the presentation will be disseminated to all participants. Thank you. Merci beaucoup. So now, colleagues, dear participants, let's now hear from our colleague Suzanne Merin from the National Institute for Communicable Diseases in South Africa, who will make a presentation on the importance of meningitis sequelae surveillance. Suzanne, the floor is yours.
Thank you. So thank you all. I'm very grateful for this opportunity to demonstrate the importance of meningitis sequelae surveillance from our experiences in South Africa. So I'm Dr. Susan Meyering. I work for the National Institute for Communicable Diseases in South Africa, and I coordinate a surveillance program on bacteria of public health. So as we have already heard today, the global burden of meningitis from 2019 was about 2.5 million cases with 236,000 deaths. And almost a third of this was caused by viral pathogens. But Neisseria meningitidis and strep pneumonia were the most dominant bacterial pathogens, with high mortality found in both these diseases. So there's also a high rate of disabling sequelae that follow bacterial meningitis, with 20% or 1 in 5 survivors suffering some sort of complication. 25% of those with Streptococcus pneumonia meningitis suffer sequelae, and 10% of those with Haemophilus influenza to 7% of those with Neisseria meningitidis on a global scale. However, the sequelae risk is not equal in all regions of the world, and it's noted that Africa and Southeast Asia see more than double the rate of sequelae than the European regions. So we have just experienced the joys and tribulations of the Paralympic Games in Paris, and what a wonder to see the resilience of these athletes with all sorts of disabilities, some of which stem from earlier episodes of meningococcal disease, which has left them with limb loss. It's a stark reminder that despite our efforts to prevent disease and give treatment where necessary, meningitis still causes significant amounts of death and disabilities. And one of the strategic goals of defeating meningitis by 2030 roadmap is not only to reduce these cases, but also to reduce deaths and disabilities in those affected. And one of the pillars deals with strengthening early recognition of these disabilities and ensuring the appropriate management of sequelae. So we need to identify those at high risk of disease, disabilities, and death, so that through our surveillance efforts, we can demonstrate the burden of disease on individuals, society, and the government. We can also raise awareness of the magnitude of the needs of those affected, and in addition, being able to quantify the burden of disease in one's own country provides useful data to use when trying to advocate for affordable vaccines and other preventable things in your own country. So South Africa is a middle-income country, and it's not Gavi funded. But according to the WHO Afro Landscape Analysis, despite not falling into the meningitis belt, it is recognized as a priority country for defeating meningitis, that is at medium to high risk for meningitis. South Africa has a high HIV prevalence, with 13% of our population living with HIV. Meningococcal disease is endemic, with sporadic cases occurring all year round due to serogroups B, C, W, and Y. Our national immunization program includes the Haemophilus influenza type B conjugate vaccine since 2000, which is given at 6, 10, 14 weeks of life, and then again at 18 months, as well as the pneumococcal conjugate vaccine, which was started in 2009 and given at 6 weeks, 14 weeks, and 9 months of age. Initially, PCV7 was used, but this was switched to PCV13 in 2011, and in 2024, we are now moving over to a more affordable PCV10 vaccine. But no meningococcal vaccine is used in South Africa. There are various surveillance programs that document disease episodes and burdens, most notably a notifiable medical conditions system, where Haemophilus influenza type B and meningococcal disease are notifiable by law. We also have the GERMS National Laboratory-Based Surveillance Program on pathogens of public health importance, with strep pneumonia, Haemophilus influenza, Neisseria meningitidis, and Group B strep being some of the pathogens that we track. There's also a DHIS system for monitoring meningitis episodes, which is in the process of being set up. So we'll look more in depth at the GERMS surveillance program. This is a national program. It's laboratory-based, and therefore all public and private microbiology laboratories in the country, of which there are approximately 200, are requested to participate and submit isolates of strep pneumonia, Haemophilus influenza, and Neisseria meningitidis to the National Reference Laboratory for further antimicrobial susceptibility testing and serotyping or serogrouping of organisms. Once a quarter, an audit is performed on laboratory information systems of these public laboratories to ensure that all episodes that meet the case definition of invasive strep pneumonia, Haemophilus, and Neisseria are captured in the surveillance program. And this then allows the incidence rates to be calculated for these diseases. In addition, we have an enhanced surveillance program at 27 hospital sites situated around the country, with at least one site in every province. These are indicated by the triangles on the map. At these sites, when a laboratory-confirmed case of strep pneumonia, Haemophilus, or Neisseria is diagnosed, we have specially trained surveillance nurses to visit the patient and collect clinical data on their treatment, their outcome, and risk factors for infection to supplement the laboratory data. And it is within this enhanced surveillance system that we set up surveillance for monitoring sequelae following episodes of meningitis. Surveillance for sequelae and mortality following meningitis was added in 2016 to the case report form, with the main aim to describe mortality and sequelae following community-acquired bacterial meningitis in South Africa and look at risk factors for both development of sequelae and death. The case definition started with laboratory-confirmed episodes of invasive strep pneumonia, Haemophilus, or Neisseria, but also had to have a clinical diagnosis of meningitis. Therefore, positive blood cultures with a diagnosis of meningitis were included. Here's a small excerpt of the additional questions that were added to our case report form. We asked about the presence of sequelae at the end of the initial hospital admission for those who survived at discharge from hospital. And we covered 7 areas. These included necrotic skin lesions, amputations, presence of hydrocephalus, new onset seizures, whether there was hearing loss, visual loss, or any neurological deficits. The table here shows the burden of meningitis as captured by our surveillance program for those 3 organisms, showing an overall invasive disease case numbers by year in the 2nd and 3rd columns, with incidence rates per 100,000 population in column 4. For example, the incidence of strep pneumonia in 2022 was 3 episodes per 100,000 population, with approximately 1/3 of cases having a clinical diagnosis of meningitis. The case fatality for pneumococcal meningitis in South Africa was 41%, with a further 25% of survivors developing sequelae. Of note is that 66% of persons with invasive pneumococcal disease were those living with HIV. There was also a high burden in infants and the elderly. With regards to invasive Haemophilus influenza, incidence in 2022 was 0.58 cases per 100,000 population, with 21% being meningitis. Once again, almost a quarter of meningitis episodes resulted in death, and 21% of survivors had long-term sequelae. 38% of these patients were HIV infected, and most meningitis episodes were Haemophilus influenza type B, followed by non-typable Haemophilus influenza. And again, infants had a high incidence. Meningococcal disease happened fairly infrequently, with an incidence of only 0.12 per 100,000 in 2022. The majority of these episodes were meningitis, and the case fatality was 14%, with 20% developing sequelae. Infants and young adults had the highest meningococcal incidence. So these graphs were taken from a journal article which published this data on meningitis and sequelae from South Africa between 2016 and 2020. And they show the distribution of meningitis cases by age category. On the left are all cases, which show a peak in the young infants, followed by a second peak in middle-aged adults, 25 to 44 years of age. The next 2 graphs are separated by HIV infection status. And you can see that the distribution of disease in the HIV-infected population in the middle is mostly in the middle-aged adults, and mostly from Streptococcus pneumonia infection in the gray. Whereas in HIV uninfected persons, most disease was in young children. This graph shows various types of sequelae that were detected among patients with pneumococcus, meningococcus, or Haemophilus influenza meningitis in South Africa between 2016 and 2020. Overall, at these enhanced surveillance sites in South Africa, there were 1,455 episodes of meningitis from the 3 organisms, with an overall case fatality of 37%. However, of note is that within 2 months following hospital discharge, a further 3% of patients had died. 24% of the survivors had sequelae, with 6% manifesting more than one type of sequelae. The most common sequelae included seizures at 11%, neurological deficits at 8%, deafness at 6%, hydrocephalus 3%, and necrotic skin lesions 3%, visual loss occurring in 2%. The main factors associated with developing sequelae included having a low Glasgow Coma scale on presentation and having organisms that were non-susceptible to penicillin. Whilst development of new onset seizures was the most dominant sequelae experienced in all 3 pathogens, of note is the high rate of deafness and hydrocephalus seen following Haemophilus influenza, mostly seen in the young children, and necrotic skin lesions following meningococcal meningitis, and neurological deficits following Streptococcus pneumonia. I chose to focus on the strep pneumonia meningitis episodes as reported in the IJID article. The meningo and the Haemophilus influenza are reported separately in there too, if you want to read further. So between 2016 and 2020, in South Africa, 41% of those patients with Streptococcus pneumonia died, and a further 5% died within 2 months post-discharge. Most of the deaths were in persons more than 5 years of age. Factors associated with death are shown in the forest plot, and when we adjusted for age, having a Glasgow Coma scale less than 15, which is not alert, having HIV infection, particularly those with a CD4 count less than 200 cells per microliter, and having an underlying illness were risk factors for death. Median time to death from specimen culture, which was usually the same day as admission, was 3 days. So this slide then shows the sequelae following pneumococcal meningitis amongst those who survived until discharge. So 1/4 of the survivors had sequelae, with 7% having more than one sequelae. The main ones being new onset seizures, neurological fallout, and deafness. 2 factors that were significantly associated with developing sequelae in survivors were presenting with a low Glasgow Coma scale and having an organism that was non-susceptible to penicillin. So here is just a summary of what we saw in South Africa, and that just to note is that I've just taken you through the main bacterial causes of meningitis, but we also have a very high burden of TB and cryptococcal meningitis, particularly in our HIV-infected population, as well as viruses that cause meningitis. But the case fatality amongst the bacterial causes of meningitis are very high, peaking at 41% amongst those with pneumococcal meningitis. And our rate of sequelae in those who survive the episode of meningitis is over 20% for all 3 pathogens. It's the large HIV population definitely impacts on the burden of bacterial meningitis in South Africa, particularly amongst those with a low CD4 count. So this high mortality following bacterial meningitis in South Africa is much higher than expected considering our social development index. And considering the case fatality rate reported from studies in Africa meningitis belt can be below 10% in some of the epidemics. Therefore, it's important to note that HIV co-infection is a major risk factor for death, along with a low Glasgow Coma scale on admission. And this high case fatality may even mask a much higher rate of sequelae than what we are seeing. So in South Africa, we see more than 1/5 of meningitis survivors being discharged with sequelae, with many developing more than one type. The biggest burden for developing sequelae lies with the young children, who still have their whole lives to live with these devastating consequences of their illness. So this platform of national lab-based surveillance is unique, as well as the enhanced surveillance platform that collects more detailed clinical data from patients with various infections. With systematically collected data from a few sentinel sites that are representative of all provinces in South Africa, we were very fortunate to be able to set up this surveillance system on sequelae that could be nested into an already functioning system. However, it needs to be noted that this lab-based surveillance is solely reliant on specimen-taking practices of the clinicians, as well as assuming that patients will present to healthcare facilities when they are ill, and therefore our numbers may actually be underrepresented of the true burden of disease in the country. So South Africa is developing their own defeating meningitis roadmap, and having surveillance data is important for raising awareness of meningitis sequelae. We can also use this data to advocate for improved basic services such as timely access to hospital care, the availability of affordable vaccines, and the need for services addressing long-term follow-up for those with sequelae. Going forward, we are planning on developing a policy brief for introducing meningococcal vaccine for first-year university students in shared accommodation, and also performing a cost effectiveness analysis for introducing meningococcal vaccine into a school age program, provided that an affordable vaccine can be made available. We are also going to be monitoring the impact of the new PCV vaccine and introducing it into at-risk adults. So I'd like to acknowledge the large team who work on our surveillance program, as well as the patients, lab staff, and clinicians that assisted in obtaining all of this data. And thank you very much for attending this and for your time now. Over to you, Anderson.
Thank you. Thank you so much, Susan, for providing such a wonderful insight into the experience of South Africa in meningitis sequelae surveillance. Thank you so much. I would like to remind all panelists that we have some questions in the Q&A which require answers. Most of the questions are in French. We have tried to provide answers, but we still need to complete them. Now we are reaching now the question and answer session. So now it's open to the live Q&A. So if any participant want to take the floor, you raise your hands and we'll give you the floor to ask your question.
Anderson, we have a hand. Letting them speak now.
I cannot see any hands.
We have a hand
raised.
from Lauda Simpara. Please go ahead and
Okay.
speak.
Okay.
Merci bien pour la modération. Permettez-moi de remercier également les différents présentateurs pour la qualité de ces présentations. En fait, j'avais une préoccupation par rapport à la détection de ces séquelles après la méningite. Comme nous le savons tous, dans les zones où sévit la méningite, les endroits où les cas surviennent généralement n'ont pas d'hôpitaux, donc pas de neurologue pour détecter ces lésions. Donc, avec ces programmes de surveillance, est-ce qu'il est prévu la dissémination des guides pour la détection précoce de ces séquelles? À vous. C'était la question. À vous.
OK, merci. Merci beaucoup, Daouda, pour cette question. Je ne sais pas si Niconi, if you could, I don't know whether you heard this question.
Apologies, Anderson, if it'd be possible to just translate that.
Okay, let me try and translate. Daouda said that, since most of the, meningitis cases occur in remote areas and where, we do not have neurologists to take care of meningitis sequelae. Is there any plan to have sequelae surveillance and management?
Is there any plan to have what?
The guides on meningitis sequelae.
Yes. So absolutely. So I would also like to bring in my colleague, Dr. Binello, who has extensive experience in treating meningitis in very, very difficult resource-limited settings. But so the meningitis diagnosis, treatment, and care guidelines are very specifically focused toward areas where there are no neurologists and areas where there are very few resources. And so we are trying very hard to teach people and train people. This includes nurses, this includes community healthcare workers, this includes primary care physicians, and also the general public. We are trying to teach them to recognize the signs of meningitis. So also Community healers are a very important part of the team as well. So teaching community healers and community healthcare workers about the warning signs of meningitis, and also teaching them that meningitis has sequelae, and that you might want to think about meningitis as a cause of behavioral difficulties in a child who has had meningitis, for example. So we are absolutely focused on these areas. In particular, my colleagues on the emergencies team are very, very familiar with this topic. So Nicolo, over to you.
Thank you, Nicolene. And yeah, I can just add to what you just said that it is very, very important, and this will be reflected in the upcoming guidelines, as was mentioned before, that the initial management, at least, of patients with sequelae is dealt with by different types of physicians, including general practitioners and medical doctors that do not necessarily have a specialty in neurology. And there's a variety of reasons for that, including having some experience working in very resource-limited settings. It's important not to deal with patients with sequelae just by referring them to a higher level healthcare facility. There are duties and activities that can be undertaken also by medical doctors that are not neurologists. They should be trained in that regard. There should be capacity building types of activities in order to ensure that the initial detection and management of sequelae is possible. But it's definitely important to avoid referring all sorts of patients with possible sequelae to a higher level facility, because the healthcare system would not be able to sustain such an approach. So this message and these messages will be reflected in the upcoming guidelines, which target primarily healthcare professionals operating in first and second level healthcare facilities in low resource settings. And it's very important from our perspective that the initial management and detection of long-term sequelae starts on the front line, at the forefront, where the patients are initially managed and dealt with by doctors that may not have a specialty degree in neurology. So that's our perspective. Thank you.
Thank you so much, Nicolene et Nicolo, for these clear answers. J'espère que Daouda, les réponses qui ont été données, vous êtes satisfait, ça va?
He can type in the chat to say if he's okay. Yeah, he can no longer. So you have 3 hands, Anderson. You have one from Hassan Swari, and which I have just given permission to speak. Hassan, please go ahead and ask your question.
Yes, good evening from my end, and I want to give a special thanks to the organizer and our presenters. My concern is with regards to the questions raised for community level in terms of identification of the meningitis. Because when I look at the presentations done, first, what comes to my mind is how equipped is our community in terms of identification of cases, and also not only in terms of identification of unique cases, but is there any case or conditions in situations in which the South Africa case, we have a individual case specific that is more or less different from the others? Because one way we can able to actually address the issue of this meningitis is when we actually try to see case-by-case presentations by the patients, because we cannot just use a generic signs and symptoms in terms of identification of meningitis, especially at community level, where they don't have the capacity to do the test. So if we have a unique case from the South Africa experience, probably we can use that for other countries, or other countries who have also registered cases of meningitis, to actually help us with the uniqueness of their own case in their community. So that one will help, it will go a long way to fight the meningitis, especially in Africa. That's my concern, and I thank you very much.
Thank you. Thanks so much, Hassan, for this concern. Yes, we have this opportunity of learning from South Africa, and like my colleague said, WHO is working with partners to finalize the development of this guide, which take into consideration detection of sequelae. And one thing I would like to emphasize, sequelae detection management is, something which should be implemented using a multi-sectoral approach with clinicians, with epidemiologists, with community leaders, civil society, social affairs, education, etc. So we hope that with this guide, which incorporates all these aspects, it's going to be very useful, in the fight against meningitis as a whole, specifically, and to address this issue of meningitis sequelae. Another important aspect is the issue of data management. Sequelae can even occur prior to even we detect it from the community level. So we need to have a good data management system where we record, all suspected cases, and we do the follow-up, once even the patient is released from the health facility. Maybe my colleagues could maybe elaborate more on this.
Yeah, I mean, I think from not just the South Africa perspective, that the Defeating Meningitis Roadmap has developed guidelines for detection and management and treatment of bacterial meningitis. And it is pretty standard, the presentation of meningitis, bacterial meningitis. And so I don't see that there's specific things that can guide, I mean, from our South African perspective, but what we did see with our sequelae surveillance and looking at what were the risk factors for sequelae, which of the patients that have a bacterial meningitis were more likely to develop long-term sequelae. I think what came up is those that presented later to hospital, that were already confused and had a low Glasgow Coma scale. They were definitely more at risk of developing long-term sequelae if they survived. They were also more likely to succumb to the infection. So that was one factor that came about. This like meningococcal meningitis sometimes it hits hard and fast. So sometimes there's not much you can do to ensure patients get to facilities quicker than they already are. But that is one of the factors that I got from our surveillance data, is that those that present already confused were at higher risk of a poorer outcome following their meningitis. Those with HIV infection were more likely to succumb to the infection, to die, but not necessarily develop sequelae more than those that were HIV negative.
Thank you, Susan. Amarachi, can we have the next? Oh no, sorry.
Anderson
Nicolene has a hand up. Yes, Nicolene.
Thank you, Anderson. Just to follow up on what Susan was saying, so there are two separate work streams that we are working on. One is detection of meningitis, and our emergencies colleagues are working on really trying to take a second look at the case definitions of meningitis, and so that we can very clearly recognize the symptoms of acute meningitis. But simultaneously within our guidelines, we are talking about detection of sequelae from meningitis. So we are addressing both the case definitions of acute meningitis as well as the detection and recognition of sequelae from meningitis. Thank you.
Thank you so much, Nicolene and Susan. Amarachi, can we have the next question?
Yes, we have a hand from Emmanuel. Emmanuel, please, you have the floor. Please unmute and speak.
Yeah, thank you very much, Dr. Sarah, for the presentation, and happy to see you again, Lats. Thanks for good moderation. Happy to see Nicole and Nicolene. Fortunately, I was one of the lucky people to be in Geneva for the meeting we held in July. On my arrival, we had started something trying to follow up on some of these sequelae from meningitis. And during the outbreak, really, we had lots of presentations of purpuric rashes, in particular, purpuric rashes. And I was looking at the registers to try to follow up on these cases. I had a senior colleague who was of the opinion that no, this is not a sequelae, okay, even though it could be signs of meningitis infection. But from this presentation, I could see the necrotic skin lesions, okay? So I'm just wondering if we could shed more light on some of these cases we had during the outbreak with the petechial or purpuric rashes. What is to what extent can we say, can we follow up these cases for these necrotic lesions? Thank you, and over.
Thank you, Emmanuel from Nigeria, for your question. I don't know, from the panelists, who is able to take care of this question? Yes, Nicolo?
I can give it a go, yes. Thank you, Anderson. So I think I will get to the question in a second, but I think it's important to also tie into what was discussed a couple of minutes ago to avoid any sort of oversimplification of the signs and symptoms of bacterial meningitis. Obviously, as Nicolene mentioned, we are currently working to improve and update our case definitions for bacterial meningitis, primarily for outbreak response and investigation purposes, and obviously for improving surveillance activities. And that's one objective. On the other hand, we do know that the clinical presentation of patients with meningitis can be extremely varied and sometimes may not fit well with any case definition. And that's a possibility, especially in patients that may present with sepsis or bacteremia first without meningitis. And that is a typical example of meningococcemia, whereby patients have primarily symptoms of bacteremia or sepsis, sometimes even septic shock, sometimes complications mentioned by Kituga now, such as necrotic skin lesions as a result of a purpuric rash, which primarily stems from bloodstream infection as opposed to a central nervous system infection. So the reason why I'm making this type of comment is just to emphasize that there are different types of bacterial meningitis. Different types of bacterial meningitis may present differently, each with its own set of complications, some of which are overlapping, some of which are completely different. Finally, and this goes back into the question that was just asked, sequelae can be neurological or physical in nature. And for example, severe skin scarring, digit amputation, limb amputation are all sorts of sequelae, primarily of meningococcal meningitis or meningococcemia without meningitis. And so as a result of them being potential sequelae, they should be incorporated in any management protocol regarding sequelae. And obviously, again, there might be different complications for different types of bacterial meningitis, but all sorts of long-term complications, whether they're physical or neurological in nature, they should be addressed by management protocols. And they will be addressed, by the way, by the upcoming guidelines from WHO. So just to say that, just to, again, emphasize that case definitions are important, but they're not the silver bullet. They should be used for outbreak investigation and response purposes. They should be used to improve and streamline surveillance and even, train physicians for case management. But again, individual presentations may be significantly varied, and in-depth knowledge of the disease, whether it's meningococcal meningitis, whether it's meningococcal infection without meningitis, should be taken into account when dealing with these patients. So this is just a call for us not to oversimplify the discourse around meningitis and its different ramifications. I hope I answered the question in the meantime as well. Thank you.
Thank you. Thanks so much, Nicolo, for answering this question. Just to add that, when we have the presentation, it's also important to look at the laboratory aspects, maybe which specific pathogens, give such signs and symptoms. So I would like just to remind us the importance of having, a good data management system, having a line list, to monitor and follow up on all those aspects. It's important to have a good documentation. Thank you. Amarachi, do we have another question?
Yes, we do. We have one more from Dembele. From Dembele. Dembele, you have the floor. Please unmute and speak. Husseini Dembele, you have the floor. Please unmute and speak.
Oui. Allô? Vous m'entendez?
Oui, Dembele. Oui, on vous entend très bien. Allez-y.
Voilà, merci pour cette webinaire très, très important. Mais sous nos contrées, nous remarquons que pour le moment, nos actions s'inscrivent plutôt à sauver des vies. C'est ça la mentalité des agents qui sont responsables de la prise en charge. Et même dans le cadre de la santé publique. C'est pour vous dire que pour le moment, on notifie peu ces cas. Si on ne notifie pas ces cas, on ne peut pas savoir l'ampleur et la gravité de ces cas et pour suggérer qu'il y a une possibilité, une section ici à l'OMS qui se charge de la prise en charge et d'évaluer l'impact de ces séquelles sur la santé de nos populations. En tout cas, pour moi, il faut d'abord passer aux collectes, aux enregistrements des cas et analyse locale pour essayer de faire en sorte que montrer l'impact des séquelles sur la santé de nos populations, que les soignants s'approprient d'abord et que ces données soient suivies et soient des données pour l'utilisation de ces données dans le cadre de nos actions futures. C'est ça que je voulais signaler. Je vous remercie.
Merci beaucoup, Dembélé, pour ces suggestions. Comme on l'avait dit tantôt, hein, il y a un guide qui est en train d'être élaboré et ce guide qui prend en compte tous ces aspects de détection, de prise en charge, même à partir de la communauté, ce guide sera disséminé dans les pays. Je voudrais juste relever l'importance de travailler avec voilà, toutes les ressources disponibles. Comment est-ce que nous travaillons avec les neurologues? Comment est-ce que nous travaillons avec les ORL? Comment est-ce que nous travaillons avec le secteur de l'éducation, ceux qui s'occupent même de rééducation, les affaires sociales, les communautés, etc. Donc, il faut que vraiment nous assurions que tout ce qui existe comme ressources, comme infrastructure dans nos environnements contribue à la lutte contre les séquelles de la méningite. Nous encourageons vivement les pays à inclure cette composante essentielle dans leurs plans nationaux pour vaincre la méningite. Si on a cet aspect bien inscrit dans nos plans, c'est plus facile de dérouler ça en activité et de monitorer, de suivre la mise en œuvre de ces activités. Merci beaucoup encore une fois pour votre contribution. Amarashji, do we have any other question?
No, there are no more hands raised.
No more hand raised. Let's have a look at the Q&A. So most of the remaining Q&As are contributions and a lot of things. So we still have like 6 to 7 minutes to go. So Amarachi, colleagues, I don't know whether we should proceed to wrapping up or.
Yes, please, if we are done with questions and answers, as it seems that we are, please, we can proceed to wrapping up.
Okay. Okay, thank you so much, for this time. It was, a very fruitful webinar, new topic, many questions, many interactions. Let me start by thanking, our colleagues, interpreters, who have been very useful, in making sure that, every participant, contributed to this, understood, the message. Thanks so much to colleagues from HQ, from the regional office, from the Dakar hub, from partners, NICD, Davikas, and also the training team, Amarachi and Jeka. You've been very, very instrumental in preparing this activity, and thank you on behalf of the whole meningitis team for the 3 level of WHO. Receive many thanks from us, and I think we are going to close now, and we are meeting again in a couple of days on Thursday, 12 September, to discuss GBS, Streptococcus agalactiae, or Group B Streptococcus. For now, just take care and see you again on Thursday. Thank you. Bye-bye.
Thank you very much. Bye-bye.
Bye-bye.
Merci. Bye.
Bye. Thank you. Bye-bye.
Well done.